Good evening. Good evening to welcome to the As Prescribed panel discussion, where we hope that we can continue the fascinating journey that you've seen on the screens the last hour and a half. I'm moderating the panel. My name is Peter Jarrett. I'm a retired psychiatrist and a trustee of the Global Film charity. Our distinguished panel starts with Holly Hardman, the filmmaker, who's going to wave her hand. She's a researcher and documentary filmmaker, and all the bios are in much greater detail in the program if you want to get a more detailed look. Our second panelist needs no real introduction. She's Geraldine Burns, who is a campaigner, as you've seen, for benzodiazepine awareness, amongst other things. And thirdly, we have Dr. Anne Gray, who's a psychotherapist, and I think it's fair to say, although she'll say more about this, a campaigner also for a recognition of the prescribed drug dependence problem. So they're our panel. Welcome to them, welcome to you. The discussion, I will ask some introductory questions, but really the discussion will be led by you, the audience, and by the panelists, and I will try and facilitate a wide discussion. But I'm going to start by asking Holly a question. And that really is how she came to be making this film and about the difficulties and facilitating elements to the filmmaking process.
Well, I'm a survivor of benzodiazepine injury. And I think like most people who have survived this, if you do make it through, and most do, you don't want to see anybody else go through what you did. And at the time I discovered I was dealing with bind, we didn't call it that then, but when I realized that the benzodiazepine I was prescribed was killing me, I was finishing another film and actually preparing it to screen at IDFA that November. That was June, and we were going to screen at IDFA in November. And at that point, I didn't think I would do much more than make a short film. But as time passed and I learned more and more and I started connecting with people and I started realizing, even just with my own experience, this was so much worse than I could ever have imagined. It was so much more complex. And it was just such a learning curve and understanding what this is all about. And one of the highlights of my early days, or my first day of discovering that Klonopin was killing me, was finding a blog post or an essay Geraldine Burns had written. And I connected to it because she wrote about driving and realizing something was wrong and starting to have these terrible panic attacks. And at the time I thought I wasn't well enough to think I was going to be able to. I didn't know that I would actually be able to make the film. But once 2 years later, I realized that I could. I found Geraldine, I found her phone number, and I called her. And she was wonderful from the get-go. And here we are.
There's a lot of disclosure by people, for all over the United States. You have many participants. Were there difficulties in that? And what were the difficulties? I don't want to focus on the difficulties,
Sure.
but I think people will be interested to know how hard it was and what the issues were for you and what made it work.
Well, Geraldine was the first. And I think Matt Samet, whose book I had read, and I found his book was recommended on a platform that so many of us use called Benzo Buddies. And I probably sent him an email and he was open to it. I think because I had a film that was out at the time that had pretty decent distribution. And so maybe I looked as though I was valid. And let's see, with Amy and Scotty, Amy came to me because we have these groups. It's not just Benzo Buddies. There are Facebook groups. And there really is this worldwide benzodiazepine community. And Amy approached, and her idea at the time was that she thought it would be great to film her husband's taper. But you see what plays out. You cannot predict what's going to happen. It was things just became more and more complicated. And then with Sam, I found his dad's Facebook post about the video that he posted of Sam being so abused by the doctor in the emergency room in California. And, there were other people that we filmed, and then the film would have been 2 hours long. I'm sorry, we had other fascinating stories, and we just had to cut back. And, I'll always feel bad about that. Just couldn't include everybody, because everybody's story is fascinating and important.
And the people willing to speak, once you contacted them, they put themselves out there already. That's how you found them, and they were willing to join in with your project.
Yes, I think filmmakers have a different way of doing things, but I find I wanted to film people who wanted to participate.
Right.
Because they're exposing themselves. It's so raw, and I didn't want to exploit people. I wanted their full protection.
That really comes over. And there's going to be so many other things that we'll want to ask you. And I can think of many things I want to ask you that I'm going to hold back because we need to give a chance for the audience. But I'm going to turn now to Geraldine. The audience will know you quite well already and understand your commitment. But I think they would be interested in hearing from you, how you set up your group in the first place, and how other supports, I think you've mentioned to me, other supports that have been very important to you, the family and so on. I'm sure we'd like to hear about that, and then about your response to Holly's, initiative about making a film.
Yeah. Well, it's so important to have support from family and friends, which I was very fortunate to have that. But in the online groups, there are people, family members have walked away from them, and so the only support they're getting is from online. So when I set it up, I'm not great technologically. I say that all the time. And, my son helped me set it up. He kept saying, you need others like yourself, because even though my family and friends and neighbors, all supportive, I had no one to talk to that was going through it. So hence comes the first online support group. We get that going, and the suffering is unbelievable. And to think, this isn't like a little problem here in Boston, it's worldwide. And my first phone call to the UK was probably my biggest lifesaver, because they had support. They had the charities where you could go for help. Here we are, over 25 years later, we still don't have anything in the United States. I don't think Canada does either, and some of the countries do, like Australia, New Zealand, we still have nothing. Now in comes Holly with the film, which we had all been saying for years, if somebody would just make a film, but I like to always be behind the scenes. I'm kind of quiet. You don't see that in the film. And I guess I had to say yes. It's like, all right, I gotta put my money where my mouth is. You've gotta put yourself out there. If we really want to make a change, I don't want anyone else to go through what I went through. And like Holly said, that's the first thing you think of. It's too late for me. It was too late for her. We want to stop it from happening to somebody else. And I'm always been very open about the fact I'm not against these drugs. I'm for the responsible use of them. There's too many that have been on them too long, like my friend Paula, and you don't want anyone to see her cut off. And that's what we see right now happening. People are being cut off. And to me, that's about as close to a crime as you're going to get.
And I mean, your initiatives at the State House, did they predate the film, or did they really all take place at the same time? The reason I'm asking the question is this: that you're saying, it sounds like when Holly approached you, you were sort of asking yourself, well, okay, I've got to expose myself even more. This is I've got to really put my money where my mouth is. Right. But you were already doing that by going and trying to get the Massachusetts legislature to pass a law.
But nobody could see me at the State House. You can't, if we went in, it was just those local people affecting Massachusetts. Now this was opening up, and Holly could probably tell you the dates, because we've been in there speaking so many times now. I think when she approached me, I'm not even sure if we had done the first one yet, or we were about to. Holly, you can tell us on the dates.
Yeah, it was interesting. Do you remember introducing me to Paul McMurtry the first day we filmed? Yeah. And we almost had this in the film. We took it out. But we sat in your living room. I met Paul, and he said, well, part of the discussion was that you had talked in the past about legislation, and he had said, well, now that we've got the film, we should do it. And so I actually can say that though he had a plan, a general plan, it became, yes, we've got this film now. Yeah. Let's do it.
Actually, you know what? When I first approached him to do the bill, he said, put it together. My son was still in law school at the time, and I was actually still too sick to do it. And then as Jarrett, graduates, and then he's now working for Representative McMurtry, it was, let's sit down and do it. And the main thing when my son and I sat down, it was protect those who are going to be going on, and you want to protect long-term users more than anything. I said, we don't do it unless long-term users are protected, that they can never be forced off their pills. And it's happening.
So, really what you're saying, from what I'm getting from what you're saying, is that actually the initiative, the legislative initiative and the film initiative were sort of going on at the same time and almost built on each other. Is that right? I mean, it's just very interesting about how film can be used, and you're giving a very good example. I think next, because I think Anne will help us with understanding some of the campaigning aspects here, and perhaps you can tell us a little bit about your varied roles, and I think perhaps your campaigning role or information giving role as well. So let's hear from you.
Sure. And what an amazing film. So thank you, Holly and Geraldine, for that. It's just fantastic to see this kind of awareness being brought to the issue, and it's just shocking as to how long it's been going on. And it's so interesting hearing Geraldine talk about even 25 years ago being able to contact the charities going in the UK who are helping people. And in many ways we haven't got too much further than those charities actually offering services, and some of those have had to close. However, the group that I work with is the All-Party Parliamentary Group for Prescribed Drug Dependence. I'm on the Secretariat for that group, with Luke Montague and Dr. James Davies, who are names that people in the UK may have heard of. And the group has been instrumental in bringing about some change in the UK. So it lobbied for and successfully got an evidence review by Public Health England into drugs that cause dependence and are associated with withdrawal. So that was including opioids and antidepressants particularly, as well as benzodiazepines and Z drugs. So and it recommended that services needed to be put in place to help people. So not only a range of preventative actions, but we need local support services run by our NHS and a national helpline. Now, we're still lobbying for those things to come into place. And we understand that there will be a commissioning framework, which is kind of the first step for our NHS to actually put services in place. That should be published in the new year, which is a huge step forward. And then we're going to be trying to work with different NHS organisations, trying to bring lived experience and professional experience of the subject to help set up these services so that they're not done in complete isolation of understanding patients' experience. And that's what's so helpful about this film, is it bringing to life the reality of these drugs and helping people understand some really important distinctions, particularly between addiction and dependence, that this is where people have taken them as prescribed. And most importantly, that this is not an issue of mental health. This is a physiological issue of adapting to the presence or absence of a drug. And so there are some hugely important messages inherent in the film, which are so vital to support the kind of campaigning that we're doing to get these services in place. And I understand absolutely the push for informed consent, and hence the legislation that you're, been so active in. The difficulty is that in order for there to be informed consent, doctors have to understand the issue to start off with. So actually, there's now a growing recognition in the UK, the importance of improving the training of doctors first, because before you have that, you can't have informed consent. So
that's fascinating, and it's interesting, very interesting to hear the UK side of it. I want to ask all of you actually this question about addiction and dependence, because I'll tell you why. I mean, maybe this is my ignorance and my experience, but when the idea of addiction is that you're physiologically dependent, and dependence is a psychological state. That was how I was trained, and I sense from what I've heard from you and read since I first met you, that actually the problem with the word addiction is it does carry a moral weight, and in other words, people disapprove of people if they can use the word like addiction, and I wonder whether some of the problem with really getting the user's voice heard is the sense of being morally condemned if you've got a dependency, if you've got a dependency problem on these drugs. And I wonder whether that's a barrier for people to have a more rational approach to it. I don't know whether you want to respond to that or simply contradict what I've said. I mean, it would be perfectly fine. Holly.
You know, Anne already said that this is a physiological illness, and that's where we need to stay. Even if somebody started taking it because of a mental health issue, where they end up is with this, you know, this central nervous system disaster, and it manifests itself throughout the body. I mean, pain, the pains, the strange sensations. I mean, there's nothing psychological about that. I will also say, as far as the dependency addiction narrative goes, or the question about dependency and addiction, is that I think it is also helpful to understand that, because we sympathize, we feel compassion for people who are addicted to substances. And but an aspect of that narrative is a yearning to take the substance, which is absent in the benzodiazepine injury and benzodiazepine dependency.
That's enormously helpful.
I've been reading very recently a summary of how these two terms came to be conflated. And unfortunately, when the DSM-3, I think, was put together, they decided there had previously been an understanding that dependence and addiction were different things, that with addiction, there was also this element of physical craving and drug-seeking behavior that would go with the dependence, with the physical dependence. But because of the pejorative feeling about the term addiction, they decided they didn't want to use that term. So they went with the term dependence, thinking they were being helpful. And unfortunately, the two terms became conflated at that point. And I think it's even interesting, even in the language you were just using there, talking about users, people are taking these drugs as prescribed. They're not using, abusing, or misusing. They're taking them because they've been told to take them. Even in that simple language, the very idea of sending somebody along to a 12-step program is just the wrong place. It's just inappropriate. And trying to get that across to healthcare commissioners, it's such a barrier to people understanding why they think these services already exist, that they're there for people to be referred to. And you can imagine a friend or family member, any of the people you've seen in the film, going along to a drug or alcohol service. It's just the wrong place.
That's very helpful. One of the questions we've had is about, I mean, I think you've alluded to it, several of you while we were speaking, to how much of an international problem this is, how widely understood it is as a problem internationally. And I suppose also one of the questions related to this was whether or not the kind of legislative route that you, Geraldine, have been trying out in Massachusetts. I know there are other states, I think you mentioned, where that might be going on, whether that's going on anywhere else in the world. I don't know who would like to have a shot at that.
I'm not sure where else in the world, except for, I mean, we've taken a lot from the UK, who was ahead of us. In fact, every time I speak at the State House, I always say that the UK, when I first called over there back in like 1997, I think, they said that you Americans should be ashamed of yourself. We are 15 years ahead of you using your scientific information. We still have nothing today. UK, still has their issues. So we also know Australia and New Zealand have, I don't think anything legally, they just have groups. So I know Sweden. I used to work a lot with the guys over in Sweden, but that website is gone. They've both gone on with their lives. Holly, I don't know if you know any other countries, but I will say this. The ASHA manual, which the actual physical copy is out of benzobookrareview.com. I get requests every country. You think of it, every country has requested that manual. This is a worldwide problem. And especially, I think everybody knows I get upset about what it does to women. Holly will tell you the first year we were there testifying, just about every woman had an issue, either had a hysterectomy, DNCs, or lost her menstrual cycle, and it took years to get it back. This is the effect it's having. And there was an article 1 year after these drugs hit the market in the Journal of American Medicine. No one's paying attention. I bring it up every year. And, young girls should never be put on this and kept on it. It's a serious problem, that's affecting our ability to have more children. I at least had 2. Others have they've aged out because it took them years to recover and they've aged out. This is serious stuff.
Right. So, I mean, I think people mentioned New Zealand and other countries.
I mentioned that market reports indicate that this is a growing market everywhere. It's easy to say every developed country, but basically every country has prescribers who are doling out benzodiazepines. It is not stabilizing, it is going up.
There was, sorry, Holly, have you? Yeah.
We're just saying the sales are still going up. The money's still being made. Billions.
There was, there was a piece of research done by the European Commission that we had some input to, and they are making recommendations for member states about informing people, about having services, about not prescribing these drugs without explaining what they do and what their long-term effects can be. But it's recommendations only. It's not mandatory. It's not legislation as such.
So really, it's really in the United States that we've seen that sort of approach so far. One of the questions,
it's something we would like to export. Other countries.
Yes, well, it's a very interesting thought about because I mean, I dare say, well, discussing the legislative approach would be something we could do, but we've had a question, I think, which sort of is also very relevant because from the film really is why psychiatrists, the questioner is asking, are so resistant to accepting this drug dependence problem of prescribed medication, which in many cases is prescribed by psychiatrists. What reasons you think there is so much resistance? And the final part of that questioner's question is whether or not you're planning to use this film and your campaign to show to psychiatrists. So why are psychiatrists resistant, and are you planning to try and influence them?
I see it as more broad-based. Yes, psychiatry, but anybody who prescribes. And maybe the first line of action would be toward psychiatrists, because I do think they're looked at as the leaders in prescribing psychotropic medications. And if we can, and we've made a little progress behind the scenes, reaching out to people who deal with trauma, and this is hardly every psychiatrist who believes that these are safe. It's just that there are enough who do, that it keeps us in this era of psychotropic medication, an epidemic of illness and injury. I also want to reach out to anybody who prescribes these. And, you know, because even in the primary care physician world and nurse practitioner world, there are many who will tell you, oh, I never prescribe benzodiazepines, yet none of them are doing anything about it. So it's the patients who seem, I think it's going to be the patients who make the change, who convince them and prove to them why.
That's very interesting. Because I was going to ask, actually, and you haven't mentioned, although your website does, the recent guidance by the National Institute of Clinical Excellence on benzodiazepine drug dependence, with a lot of, with a very actually huge literature review, as no doubt you've seen, and a lot of sections on withdrawal and so on. And I think the APPG felt that the user's voice had not been heard enough. And I think the other comment the APPG made was that there wasn't information about how the patients could find their own tapering scheme, which I think is the great strength of the Ashton manual that Geraldine mentions. Anyway, I don't know whether you wanted to comment on this.
Yeah,
it's rather impressive in many ways, I thought.
I mean, the fact that NICE actually have a guideline on safe prescribing and withdrawal is a huge step forward, and we were instrumental in bringing this about. It was just very disappointing that they chose not to include, and it's not only details for patients on how to taper, they didn't include details for doctors on how to safely taper. Now, given that the Royal College of Psychiatrists has actually published an incredibly useful patient information resource on how to safely taper antidepressants, you know, this information is out there from very reputable sources. NICE declined to include it, and they also declined to allow evidence from the thought leaders and academic leaders in the field. So even though their methodology allows them to include the best available evidence, because it wasn't randomized control trials, they refused to allow it in. So in fact, one of our Secretariat members, Luke Montague, was on the committee working on that guidance, and he resigned from it because they didn't allow all of this information through. So it's great in the recognition. It's just disappointing that it didn't go far enough to actually allow safe prescribing and withdrawal. And I think just adding to that, that there are now quite a few, and I'm just interested to hear what Geraldine was saying about deprescribing initiatives where people are being taken off drugs. We've got a few deprescribing initiatives kicking off in the UK, but they don't mention withdrawal. And of course, they are therefore in danger of making the situation worse. So whilst it might be about, you know, recognizing that people are taking multiple drugs and it's probably not helpful, and cost savings, if we don't provide withdrawal support, they're just going to be making the situation worse, unfortunately.
I think that must say, speaking as someone who has had many patients on benzodiazepines and tried to work with them to reduce them, actually one was in the dark as to how quickly to do it, and one applied various rules of thumb. And if you listen to the patient, actually, you know, if you're normally used to doing it more quickly, you could be quite frustrated by feeling that you've got to do it really, really slowly, because you just can't get the patient to do it any faster unless you just withdraw, which is dangerous. So the point you make is an important one, because I was thinking the NICE guidance is a way to answer the questioner's question, where psychiatrists and primary care physicians and all the rest of us would be looking for guidance as to how to carry out the treatments.
For those people that actually run services in the UK, sorry, Holly, I'll just say this, that we've actually recently discussed and agreed there is one measure and one measure only, which is useful for any kind of withdrawal service. And that is the dose reduction that is been able to be made over time at a pace that the patient has agreed to, and that allows a level of withdrawal symptoms that is tolerable to the patient. And however slow that is, that's the right pace.
Yes.
There are no prizes for speed.
Yes, Joe, I mean, because you were helping your friend with this process. I mean, do you want to comment on Anne's remarks?
Yeah, that's actually perfect. It should be slow and at the person's their pace, because everybody has different things going on in their lives. And Actually, Paula's own doctor, we went because she was falling and getting concussions. I was taking her to all these neurologists. One was saying, oh, it's not the drugs. Finally, when we go to her doctor, she's like, I agree, it's the drugs. I don't know how to help you get off. It gives us carte blanche that, we can do it. But she now does have a wonderful doctor helping her do a micro taper, but she's been on now, like, I think 40 years. But if you saw her today, she is cognitively so much better. And it has to be at her pace based on what's going on. It's been so long. Somebody might be able to go faster. And this is why I think we spoke about this the other day and we all talked. The biggest thing we see right now in the online support groups, which I will say, I would thank God for the UK and what they were doing over there. They were being bombarded with Americans calling their support lines constantly. I think they're getting exhausted. With all the online groups now, there's so much help. There's more information, but it's important the biggest problem now are doctors cutting people off cold turkey. You walk in, you see a sign, they list all the benzodiazepines and that they're no longer prescribing. It has to stop. There has to be that education. I wish we had more going on here that you have going on there. That's what this film is about. It's going to bring that awareness. You can even, in the film, you've got the doctor saying, we are part of the problem, and they want to help, and then the other one's denying it. It's crazy. And I love the fact that it should be in the medical schools. In fact, in South Africa, Felicity Bailovich, who wrote her benzo books years ago, it got to a point she would have to go and speak to the medical students before they graduated to explain about benzodiazepines. We need something going on here. Again, there's a purpose for them, short term, and explain. And we do want to protect people on them long term. Somebody might never be able to come off. And if that's the case, we can't disrupt their life. It's been too long. Let's say happening.
That's a very helpful. I keep on saying that because everything you're saying is very helpful. But I actually got a sort of relevant, a question very relevant to what we've been talking about, the user point of view, because what she's saying is that she's been on Xanax and her doctor says, oh, well, I want to put you onto Klonopin or some other benzodiazepine because it's going to be far easier to withdraw you from that. And so the question that we're being asked is, well, how can I educate my doctor? I mean, this is the problem that the individual patient is facing. What from your experience, what would you say? What is the way to influence the individual doctor in front of you?
So do you want me to answer that one or Holly?
Well, start with you, Joe, and then we'll ask Holly.
So, I mean, and again, I love everything that Heather Ashton did for us. And she and Dr. Reg Hurt believed 100% in switching over to Valium. But we've done this for so many years. For some, switching over, some have switched to Klonopin and done very fine. Some preferred Valium. Some went over to the long-term ones, didn't like it, jumped back onto the shorter acting. So again, it isn't a one-size-fits-all. So if some of them had to jump back, let's say to a shorter acting one, they know to level it out. But I also am a big believer in my podcast of saying, you don't just start tapering from an unhealthy body. I believe in building the body up for a few months or work with a functional medicine doctor, but you don't have to. I wouldn't just get up tomorrow and go run a marathon. I would start eating right. I'd start training, get the right sneakers, whatever. It's the same with benzo withdrawal. There needs to be an education to start. And when you start doing that, we even did that with Paula. We had her start eating better. Because if you go back to why she got put on them years ago, she went in with a migraine and comes out on 3 milligrams of Klonopin and an antidepressant in her 20s. Nobody talked to her about her horrible diet.
I mean, one of the points about the question, I think, was if you're being prescribed by Dr. A, and Dr. A has a bullish attitude to withdrawal, which is not going to work for you, how do you set about educating?
I would recommend that they visit a few websites. They could go to the Alliance for Benzodiazepine Best Practices. There's excellent information there that is specific to the prescriber. And they could visit Benzodiazepine Information Coalition. There's wonderful information on their website, also known as BIC. And then Easing Anxiety is another site that provides excellent information. And if they're willing, if they would listen to Geraldine's podcast, she always has, and she does it in sort of this down home way, sort of folksy way, I guess you might say. And it's just full, every episode is full of these gems of information, these insights that it's rare that you find somebody who knows as much as Geraldine does.
Yeah. Well, my last, because I'm away and I don't know when I'll be home again, my last one I did was directed at prescribers to listen to their patients. And I tried to put in there everything over the years, not the anger. I tried to do it, how we're gaslighted, reasons people were put on, books that have been written. Everything's there for anyone who can prescribe. And, here's another horrible thing that's happening. When somebody does go into their doctor to talk to them about, I think this drug is making me sick, I think I have to come off a bit. We just had a nurse practitioner cut the patient off because they questioned her. She was questioned, cut her off. This girl's tried to send this nurse practitioner so much information, from all the websites, cut her off and left this girl in a cold turkey withdrawal. Again, something has to happen. This has been going on. In fact, when I first contacted the UK, they said to me, be careful what you do, because even over there, people started to be cut off if you question. So you almost have to, again, I took myself off. It was finally my gynecologist after my hysterectomy that said, you're on one of the most addictive drugs ever made. And there was nothing. So I came off way too fast. In hindsight, I wish I went back on, got myself healthy, but that didn't happen. So, but there's just so much misinformation. If it could start in the medical schools, that would be great.
Anne, thank you very much, Geraldine.
Yeah, I think there are two things here I'd speak to. One is sort of a very practical thing in the UK that, Peter, you may obviously be aware of the Maudsley guidelines, which are used fairly widely in the UK. They now include deprescribing. They now include how to do proper slow tapering. There is a section on each drug in the Maudsley guidelines, and there will actually be a Maudsley deprescribing manual that I think is going to be published next year. And Dr. Mark Horowitz, who has been leading the field in terms of hyperbolic tapering, particularly for antidepressants, has been working with David Taylor on that. So that's another very reputable source of information for doctors, perhaps particularly in the UK. But I think I'm hearing in what Geraldine and Holly are talking about, it's the power issue. There's a power issue between doctors and patients. And as a result of all of this campaigning work I do, and I've done quite a lot around the field of psychological therapy in this, I've had clients come to me for withdrawal support, and I hear how careful they have to be about what they tell their doctors. Yeah. They are having to manage their doctors. They're having to edit what they tell them in order not to disrupt the prescribing pattern for them. Yeah. And they get all of their information online. I'm afraid that's just the reality of it now.
And I believe on benzosupport.org, if I'm right, there's actually a letter on that, how to talk to your doctor, because so many were being cut off. I mean, it's that we actually have to do that, and then some, when they kind of mentioned it, they just start doing it themselves. We had one person, her doctor didn't want to hear anything about it. She weans herself off. When she's finally off, he said to her, well, you seem so much better. See, the Xanax rewired your brain. And she said, I'm off of Xanax and I'm going to sue you.
The treatment worked.
How crazy is that? Even my own doctor, we're talking years ago, my doctor, I brought her in the packet that I got from CETA, 25 plus years ago. I brought her in that. I brought her in, I'm not sure if it was Peter Bregan's book, Dr. Bregan's book, gave her those. She looked at them quickly, handed it back to me, and said, you don't have a problem with these drugs. You took them as prescribed. And then she wrote out a prescription for Ativan. Now I'm off. Wrote me out a prescription, handed it back to me and said, you need to be on it for the rest of your life. So I went to her for help, and she wants me to go back on for the rest of my life. And right there, as I sat in front of her, I knew I would sue her. Now, because I go to you for help, and you're denying it. Here's this organization in England, and you're saying they don't know what they're talking about. And I was
Yeah.
so I'm coming back alive, even though I was deathly ill. It's like, I used to work in human resources, and I thought, you're treating me like this? You drugged me for 10 years and I'm out of the funk now. And my anger, and it's, anger's good and anger's bad. I took my anger, I did something good with it.
Yes, and
Starting the groups and helping others. But it was a pharmacist that came when I talked to a pharmacist. It was a pharmacist that actually, he knew me when I worked. And he said, the only way we're going to get these doctors to stop is lawsuits. You have a clean record prior to, because you got to have a clean record. He said, it's the only way to pay attention. So I did it. Not that we did great with it. I mean, but because
I think
happened. But
I think, Geraldine, I think the film and what you've told us, what Holly and Anne have told us, is a difficult story. But I think that you are making changes. You are making having effects. There does seem to be some hope of changing prescribing, increasing knowledge, and using the film for campaigning. I know Holly is going to be doing that with you all, because I think, unfortunately, we've come to the end of our time, and I've got to finish. And as is so often the case, we could go on for much, much longer, and I wish we could. But I really want to thank you very much for the film, which I've seen twice and really enjoyed. I want to thank Geraldine for her contribution to the panel and for all the work and commitment you've shown, and Holly for the same in the form of filmmaking, and Anne for your work in the panel, and for your work in the campaigning organisations you're in. So thank you all very much. I also want to thank the audience very much for your attention and for your questions. And I want to finally thank the unsung heroes of the showing, which is the volunteers, whose names were all on a post-it note that I've now managed to find. Rose, Timo and Vishal, but there are 14 volunteers in total who've helped with this festival, and we want to thank them. So thank you all very much, panel. Thank you, audience, and thank you, volunteers, and thank you, Jerry, for organising the whole thing. And good night.
Thank you.
Thank you. Thank you all. Thank you, Jerry.